We're here at the International Conference in Vancouver. We're here with Trip Gulick, who is with Weill Cornell University in New York, and he has graciously allowed us to grab some time from him to kind of digress and go back a little bit in the beginnings of the end, or however you want to put it, the end of the beginning, or whatever it was, back 19 years ago. So take us there.
Sure. If we go back 20 years to 1995, we had 4 drugs approved: AZT, DDI, DDC, and D4T, and recommendations were to use 1 drug. Everything changed from the summer of 95 to the summer of 96. And the summer of 96 was the big Vancouver meeting. So what happened over that year? First, we learned that combination therapy, 2 drugs is better than 1. A bunch of new drugs hit the scene, drugs like 3TC, for the first time the protease inhibitors, for the first time the non-nucleosides, and we had the viral load test so that we could actually test the regimens to see how they did. So it's important that we're here today in Vancouver, because in Vancouver 1996 we heard the first 2 big studies of triple combination therapy. I was fortunate to present one. I was an assistant professor, a young guy at the time, and I presented AZT, 3TC, and indinavir, and we had an unprecedented fall in viral load below detection. We didn't even know what to call it then. We said, you know, it's not gone, it's not 0, what do we call it? And we came up with below detection. And in a second study presented by Julio Montaner, who's actually from Vancouver and is the chair of this meeting, the local chair this year, presented the other study, which showed AZT, DDI, and nivaripine also reduced viral loads below detection in a majority of people. So here we are looking back 20 years, those 2 regimens, very effective, but very toxic and very inconvenient.
But everyone was just ready to get on them and enduring the drugs and all of their side effects and all of their rigor that went around the regimenting and the dosing and whatever was going with it. Much the way I guess we did with the hepatitis drugs early on.
Absolutely.
And everything has changed with that. Everything has changed with the treatments we give for HIV as well.
That's right. So the regimens back then, life-saving, but 20 pills divided 3 times a day, and you had to be fasting. You couldn't take the pills with food in your stomach. It was incredible.
And then also the issues of taking enough water to avoid the stones, and you know, and it was Q8 with with one drug, and the other drug tastes like gasoline. And
it was really tough. So if we say that the first 10 years of HIV therapy was to develop an effective regimen, the next 10 years was to develop safe, tolerable, and convenient. And it took exactly 10 years. 96 to 2006, we had our first 1 pill once-a-day regimen. And of course now we have 4 of them today. And that's why we're here, is to hear what else was new at this meeting about antiviral therapy.
So the biggest challenge that I think we as community activists have seen is the challenge to get drugs for the few, the very, very few that can't go to undetectable and that are in dire need of new drugs. The pipeline has really become shrunk because the demand is so small, but there is that population.
Sure.
And how do we address that?
So there's some good news coming out of this meeting, actually, and we're addressing it in a couple ways. Almost everyone can take 1 pill once a day, but not everybody. And so we need other options for people that have trouble with that. And so there are new long-acting injectable antivirals that are being developed, and we heard some of that data here today. So they're going to use these as infrequently as dosing an injection every 1 month or even every 3 months, and studies are in progress to see, well, could we do an all-injectable regimen for people who have trouble taking 1 pill once a day? And then you mentioned the people that have developed resistance to many of the drugs we have, and as you say, there aren't a lot of people who have experienced failure on all the current drugs, but there are some, and we need new drugs for those folks. And there was some good data here to show that there are drugs in the pipeline which could help. One example is a drug called doravirine, which is a new non-nucleoside, which is active against viruses that have developed resistance to all the non-nucleosides that we have today. And so we heard phase 2 results showing in treatment-naive people that it was safe, tolerable, and had good virologic efficacy compared with efavirenz. So that's one step. Then there's 2 new classes of drugs that we heard some data on. and drugs that work brand new ways from the ones that we have. So one is a new class called a CD4 attachment inhibitor, and it actually binds to the virus even before the virus attaches to the T cell, specifically to one of the proteins on the outside of the virus. And so we heard some phase 2 data here to show that that drug gets good levels in the blood, seemed to be well tolerated, and importantly, had virologic effect, so did reduce viral loads. A third class is coming. These are called the maturation inhibitors. If that sounds familiar, we did have one of those.
Started back a number of years ago, yeah.
Yeah, maybe 5 years ago, called Beviramat, which worked, but the problem was about 50% of people had at baseline were essentially not susceptible to this drug. So if you have a drug that doesn't work for 50% of people right off the bat.
The bar is so high for all the drugs have evolved because there will have to be one better than the next. And the bar is so high now that it makes it really difficult to build a drug, to create a drug that is going to be serving that infinitely smaller population or special populations or evolve to a yet better than the next one so that it would be the better drug to take than any of the others previously.
Sure, I mean, you could say we're a victim of our success because the drugs that we have today, once a day is sort of the rule, maybe twice a day, but once a day, got to be really well tolerated or we won't use it today. And then has to be, in some cases, active against resistant virus. So we wouldn't use drugs that didn't fulfill those properties. One other approach worth talking about and relevant to people with resistant virus, there are these new, what are called broadly neutralizing antibodies, or BNAbs, and those are getting a lot of attention. And what these are naturally occurring antibodies that people with, initially isolated from people with HIV early in infection who developed these responses. They were able to extract those antibodies, characterize them, and then grow them in the laboratory, or I should say synthesize them in the laboratory. And they're now being tested both for therapy, because they do have an antiviral effect, and also for prevention.
And also for cure, presumably.
And people are looking possibly that this could have a role in cure as well.
Yeah, we talked with Dale and Betty Bumper's Institute director, and that was one of the press conferences that he presented that at. It seems as though there's a lot of little pieces at this conference, and so when people say there's not much going on, there's a lot going on, but it's little incremental steps, and I think that's the way the whole field has moved, incremental steps. But dramatically, prevention this conference, new antivirals, and now the hepatitis has come on its own. We need to try to find a way to get access to that at affordable rates. So there's an awful lot at this conference that really jumped out.
And then probably the biggest news at this conference was that everyone with HIV should be treated, regardless of T cell count.
Right. And maybe we should say the same thing for hepatitis.
Well, yeah, no, it makes perfect sense.
Because treatment is prevention in both cases, and we're hopeful that we can find that affordable moment where there's a drug that, and also the negotiations can be made for countries that are really deserving and really needful of it, especially developing and middle-income countries as well.
I'm trained as an infectious disease doctor, and I always say, what infectious disease do we wait to treat?
Yeah.
There were very few. People would say HIV. Now we know that that's not right. We should treat right away. And people used to say hepatitis C, and now we know that's probably not the right approach either.
So it's really, there's a huge investment and a poignant moment in responsibility to take the advantage of treating early and getting all of the people who would have been infected off that chart, off that list. So the more we treat right now, if we had this moment and just said Manhattan Project, we're just going to give everyone treatment and find a way to make that happen, boy, the future would be very different.
And I live in Manhattan, so we do have this project.
So you do have a project that's working, with your governor, I guess, and so forth, yeah.
Right, just to say more, our New York governor was the first public official to say, I want to end AIDS, HIV in my area.
What a wonderful statement that is, and what an action that is. That's putting the work where not just words, but actually the message and the mission out there on the table. So if we had more that would demonstrate that, and now of course we're going to be watching, so we'll see how that rolls out, and hopefully it'll be a success, and hopefully others will use that as a model.
It's
in
pretty
other
great.
countries, yeah.
He has a 3-point plan, and it's very simple. Know your status. If you're positive, get treated. If you're negative, take PrEP.
Yeah, right.
And that's as simple as it is.
So, and that's one of the things that I think Julio has been saying for years is, okay, we're all for PrEP, but we need to find out who's positive. I mean, and so really getting tested is the message. Getting tested, and as frequently as is reasonable for your risk, and whatever that is. Maybe you need to be tested every month, maybe you only need to be tested every year, but find a realistic testing plan, and then make sure that we know, or you know as soon as you can, that you are positive, or being prepped.
And if you find out you're negative, stay negative.
Exactly.
And keep on being monitored and do everything you can.
I also am understanding that there is the possibility of transmission of hepatitis C through sexual relations. So there is an understanding of what that might mean, and I think I'm trying to look, Jürgen Ruckstra, I think, is going to give us some direction in that way as well, to understand better how that more or less happens. We understand that it happens in hospital settings and injection needles and so forth, but here we have an opportunity to understand better how the sexual transmission of it occurs.
We used to, as you say, we used to not think that hepatitis C was passed by sex. Now we know conclusively that it does, and it's probably related to blood. So if blood's involved in sex, which it sometimes can be, that can easily transfer the virus.
So maybe that's a simple message, but
Right.
then there are understandings of what kinds of sex and so forth cause the blood and so forth.
Absolutely.
But I think that's good. We need to get that out there, because I don't think a lot of people in the community know that or understand it, and because I'm just kind of learning it myself. So
I think you're right.
that's a story. Yeah. Trip, really good. I appreciate the time with us.
Sure.
And
Happy
look
to
forward
be here.
look forward to visiting with you again and follow up, maybe in another 19 years or 20 years.
Great.
We'll both be tired and still be here. Still be here.
Thanks.
All right.